Okay, we're
Got it.
ready.
Well, good afternoon. Welcome to our Clinical Culture and Diversity series, where we develop cross-cultural competency for the clinic. Thank you to all of you who have joined us here today. It's great to see you. Today, we are covering the topic health through the eyes of culture. So we are actually on our last date for the 2023-24 Clinical Culture and Diversity series. Next year, for the next series, that will start on September 17th. And we will have, again, a regular schedule, which is one in September, one in November, one in February, and one again in April. We are fortunate in that we're able to offer continuing education for this series. And so our continuing education learning objectives are to identify own unconscious biases, explore issues related to intercultural communication in the clinical setting, and develop cross-cultural competencies to improve patient care. Please note that if you are wanting to receive the continuing education credit, we would need you to sign on in the proper way. Make sure that your full name, first and last, is on your name on your Zoom camera there. And these are our continuing education credit statements for the Clinical Culture and Diversity series. And we have done conflict of interest disclosures by all of the organizers and our presenter today, Dr. Kamenelis. Here are the directions for obtaining continuing education credit. Don't worry, you don't have to remember this. Alexa will put it in the chat, but also after today's presentation, she'll send a follow-up email. She always does, and we always know she does. It will include information about the presentation, the recording, and how you can get that continuing education credit. Okay, we got through the nitty-gritty. So now it's my pleasure to be able to introduce my friend, Dr. Nicholas Kamenelis. He is the president and professor of InMed, Institute for International Medicine. He is also a part-time faculty at Research Medical Center Family Medicine Residency. Over a 2-year period, Dr. Kamenelis served inner-city citizens at Shanghai Charity Hospital. Over another 2 years, he led a healthcare ministry in the war-besieged nation of Angola in Southern Africa. Dr. Kamenelis next served for 6 years in the Kansas City Public Hospital before launching InMed in 2003. He graduated from the University of Missouri, Kansas City School of Medicine and St. Louis University School of Public Health, and was a family medicine resident at John Peter Smith Hospital. Dr. Kamenelis also earned a professional diploma in tropical medicine from the Walter Reed Army Institute of Research and became board certified in both public health and family medicine. And he's a common name around our parts at KUMC. We partner very often with InMed. They offer great programs, and he's always a willing presenter and is often invited into different groups to share his experiences and his perspective. So thank you, Dr. Kamenelis, for your willingness to be with us today. And I'm going to turn the microphone over to you at this time.
Health through the eyes of culture. So I have a scenario that I'm going to start with, and I'm going to describe this for you in a moment. And then I'm going to ask you all, what kind of advice would you give for managing this difficult situation? So here's the situation. The patient, 40-year-old African person from Accra, the urban capital of Ghana, West Africa. You, the patient, consider yourself to be in excellent physical health by the standards of your upbringing. In your culture, slim physique and intense physical labor are signs of poverty. May even suggest poor intelligence. you're not really a proud person, but you are satisfied that you are quite educated, professionally trained, and have never needed to expend yourself by working in fields or markets or factories. Now, you realize your body is a little plump compared to others, and that you need a stop occasionally and rest when you're walking in from the parking lot. But these are no concerns given the overall fitness that you enjoy. You're looking forward to visiting your health practitioner for the first time. All right, now you're the practitioner. You've never lived outside the United States, and you are very aware that health risks are associated with obesity and sedentary lifestyle. You also believe that patients themselves are the best advocates for their own health, and that your role is primarily to facilitate them towards better health. So you have just met this 40-year-old person from Ghana who is 5'4", 210 pounds, BMI 36, blood pressure sky high, glucose sky high. Your patient is winded and breathing harder than you would expect for someone walking in from the parking lot. You express concern and recommend an aggressive plan of diet, weight loss, exercise, but your patient doesn't seem to recognize any problem. All right, so I want to open it up and ask you all, how would you handle this? What would you say to this patient? How would you intervene? Luisa, I see you smiling. Do you have some advice?
I'm smiling because it's difficult when you have to approach it with a different culture than yours. You want to be respectful of their own beliefs and make sure you use wording that doesn't hurt any feelings, but still gets your message across. It's complicated. I don't have a way to say how would you say it, but I'm just laughing at thinking of the situation if I found myself in it.
All right, thank you.
I also don't know exactly what I would say or handle, but I do know when I lived in Ponape, they often would say "cochichila," meaning you're skinny, and that was like an insult, or "comororo," and that was a compliment, and that was like you've gained weight. And yeah, and that's what everybody wanted to hear, is that they were, for the same reasons you mentioned for Ghana, like if it meant your husband's feeding you well, you're well taken care of, you're rich.
Yeah, excellent.
I guess I think I would want to know what the patient's concerns are, right? Like, you're concerned that she's getting winded coming in from the parking lot and her blood pressure is high and her glucose, which are things that she maybe hasn't necessarily felt the effects of, but like, are there concerns that she has related to things that she would like to be able to do easier? And of course, if she's like, no, I feel great, everything's easy, I don't mind that I, get winded, then of course it's going to be more challenging, but starting kind of with that, and then probably knowing that like that's a ship that may be helpful to steer toward, like lowering your blood glucose and helping her lower her blood pressure and some of those things. But starting out with everything at once, you're going to just get like the door in your face. And so starting with building some relationship first, and then kind of starting with where she is, maybe would be one place to start.
Yeah, excellent. Right. Is there any problem perceived by the patient themselves? Right. Like maybe knee pain, or my clothes don't fit, or finding a felt need that you could potentially address. Yeah, excellent. Well, so my story got started with an international rotation that I did at the charity hospital in Shanghai, China. And they were very friendly, and they said, whenever you can, we want you to come back. And so I finished my training, and I went back at a time when poverty was still rampant in China. Doctors were making $20 a month, and tuberculosis was our #1 hospitalization diagnosis. This was in the 80s. And then in the 90s, I responded to an invitation to do a medical work in Angola. And this was a country that had more landmines per person than any other country in the world. And measles and malaria were rampant. at that time. And these connections between our culture and our health were really drilled into me, through some of those experiences. I want to ask all of you, aside from physique and body habitus, what are some other connections between our culture, our behavior, and our physical health? What else comes to mind?
Some food
Emotions?
options that we normally eat.
Say again, please.
Like some of our normally consumed food options.
Mhm.
Okay. Yeah, is there one in particular that comes to mind, or?
I don't know. I was raised on a farm. We eat lots of red meat.
Okay, sure, that's good.
I think movement is definitely a part of culture. So like if you're living in Europe where people walk to stores, or they live, even the way their towns and cities are created, it's so that people walk to the store and their stores within walking distance. Whereas Kansas City, there are places where it's harder to get to a grocery store, farther away. So that affects that. An interesting part of culture is how your whole city is constructed or arranged, or village.
Yeah. Thanks. Give me one more. Someone else. What's a connection between our culture and our health? So we could talk
I
about
put feelings and emotions in the chat because
Mhm.
depending on the culture that you come from, you are taught to process your emotions differently. And that has a direct relationship with the way you actively engage in physical activity.
Yeah, thank you. Grace put in spiritual needs, meditation, yoga. Yeah, we could talk about substance abuse, firearms, seatbelts, sunscreen. Yeah, lots of connections between our culture and our health, and also about how we describe our health problems. What is it that prompts us to go to a practitioner is somewhat culturally influenced. So let me give you an example. I have a headache. All right, I'm a layperson. I'm not medical. I have a headache. So what kind of practitioner could I go to help me with my headache? What are the options? Who could I go see for a headache?
Your PCP.
Okay. PCP is booked up 6 weeks in advance. I got to do something else in the meantime.
Urgent care.
Okay. Has a big copay. Can't go to urgent care. What else?
My mom.
Okay, there you go. Yeah, now
my
we're getting
mom.
there. That's right. Call your mom, call your brother, yeah. Who else could help you with your headache? Okay. Corinne says chiropractor, massage therapist. Yeah, come on.
I would look it up online.
Yes.
I'm going to Google.
Dr. Google. See your ENT. Maybe your counselor, maybe
Mhm.
pastor, maybe spiritual. Those things are by upbringing go to how to manage that. Well, so let's setting. If we, the healthcare professional, don't understand what the patient is saying or have got misgivings, then of course we're more likely to do more tests and drive up costs. And maybe whatever kind of recommendation we have for our patient, they may or may not actually understand. because of cultural barriers. So let me throw this question out to you. Examples of culture influencing health include all of these except one. Which one doesn't make sense? What do you think? Just say it out loud. Well, it's kind of a wordy question, but the answer I'm looking for is B. So people with higher levels of self-determination actually are more motivated. So we often think of the type A stressed personality being more likely to suffer a stroke or myocardial infarction. But actually, those people also are more likely to recover because they have got this driven, achievement-oriented approach to health. One of the things that's different about health professions education today compared to when I was younger is this emphasis on cross-cultural skills as one of those key components, in addition to physiology and biochemistry, pathology. So there's 4 components that I want to touch on briefly in the next few minutes. And these include being aware of differences between us, expressing attitudes of respect, some fundamental knowledge of cultures, and this process of observing a conflict, understanding the reason, and making an adjustment. And then sometimes we need interpretation. Sometimes because of differences in language and culture, we need someone who can close the gap between us. So let's start with awareness of differences and biases. Now, I'm going to say the name of some cultures, and I want all of you to think to yourself, what's the first impression that comes to mind? Now, I'm not going to ask you to say it out loud. This is just between you and yourself. So here goes. Asian, Syrian, Black or African American, Hispanic, Caucasian. So when I say words like that, they usually trigger something within us. That person is Black, must be a great musician, wonderful dancer, athlete. That person is Hispanic, really hardworking, dedicated to family. That person is Asian, curve buster, top of the class. That person is Caucasian, very narrow-minded and untraveled. Now, how do you feel about statements like that? Cooper, what would you say?
Well, I think that people have thoughts like that. Sometimes it's unconscious bias coming through, and it's a thought, and we have to become aware that we're thinking, and we have these stereotypical thoughts so that we can counter them, so we can not act upon them. So that if someone's wearing, for example, traditional dress, I don't assume that they don't speak English. I should approach them normally, speak to them normally, let them identify themselves and reveal whether or not they speak English or not, right? So it's becoming, we should develop an awareness, because we do have these voices, these conversations that we've acquired by being part of our society of stereotypes and biases.
Yeah, thank you. Yeah, and Cooper, I appreciate your comment here about, yeah, dangerous to make assumptions right off the bat. We have to self-reflect. And yes, those assumptions may not have anything to do with the actual person that you're interacting with. And so being aware of our own tendencies is one of the first steps towards accurate communication with people. Second is attitudes of respect. This is a wonderful little book that I recommend for people before they do their international rotations. Survival Kit for Overseas Living, which says we all believe in our heart of hearts that our race, our culture, our group is the most important, worthy, sophisticated. Unfortunately, this is a destructive impulse from which war, hate, oppression, and prejudice flow. Yeah, we have to be so. In a scenario of you interacting with this, say, this Ghanaian patient who's very different from yourself, how can you show respect for that person in that one-on-one clinic setting? Can you give me some tips?
Someone said it earlier, and I think this is most important, to try to connect to the person. So the first step would be to create a connection. I think trust comes from connection. So, just human to human, whether it doesn't matter that it's healthcare provider to patient, trying to ask some questions, get to know the person a little bit, share a little bit about yourself, starts with basic introductions, and then just trying to get to know the person and understand, so you don't make assumptions. So really you don't even know why that person came to the appointment. So tell me a little bit about yourself. Why did you come today? What is your lifestyle? What are your concerns?
Mm-hmm. Yeah, thank you. Cooper wrote, showing humility, asking questions about their culture before making decisions. Sure, being inquisitive and asking open-ended questions. When I'm to Angola, Enrique is my Angolan counterpart, and he said right up front, he said, you need to be very humble. And he actually quoted a scripture to me. He said, remember what Philippians says? Don't do anything out of selfish ambition or vain conceit, but rather in humility, value others above yourself. And he said, Dr. Nicholas, if you will do this, then you will be off to a really good start in your relationship with Angolans. Which one of these is not a component of healthy cross-cultural relationships? What do you think? Karen, can you help me out?
Well, I'm thinking it's B, right? Except that something about B, even though I think we try hard, there might be a little bit of that we might have a hard time working out of ourselves.
Yeah, that's right. Yeah, real careful about not coming across as superior, because that's usually poison for these kind of relationships. In the chat, I put a link to a little 1-minute survey, and this is a chance for you to send me some feedback about today's presentation. That's really helpful for me because I'm always striving to improve talks like this. And so if you would click that sometime in the next few minutes and send me some thoughts, I would be grateful. Number 3, knowledge of cultures. So knowing a little bit about that particular group, can be really helpful. So on my international rotation as a resident physician, I went to Burkina Faso, West Africa. Don't know anything about Burkina Faso. Don't know anything about West Africa. And so I'm going through immigration, and And of course, I'm really tired. And there is a young man with a big gun, and he asks for my passport. And so I reach in my pocket and I pull out my passport and I say, here it is. Oh, his eyes squinted and livid. And everybody in the room, they were like, oh, and I'm standing here with my passport going, you wanted my passport? What was I doing wrong? Somebody?
Is it because you're an American?
No? What hand am I using? So I had no idea that in that culture, the left hand is only used for one thing. And you would never use your left hand to gesture at someone or to hand them something. The left hand is the toilet hand. Some knowledge of cultures may really, really help you. And then there is this process of observing a situation, trying to understand why, and then making an adjustment. Observe, understand, adjust. And this is the main takeaway from today. So we observe what's happening, who is upset. Try not to make a judgment or an assessment really quickly, because what you need is some understanding. So here's the situation. I saw this woman who brought her 6-week-old babies for their first newborn baby check. And the next day, she returned to the clinic here in Kansas City, and she was livid. And she said, onde está aquele médico que está a fazer mal às minhas criancinhas? Like, where is that doctor who put a curse on my babies? My babies are crying and my babies won't eat and my babies have fever and that doctor put a curse on my babies. And everybody in the clinic, they're like, oh my gosh, let's get out of here. And I'm in the back and I hear this woman screaming out front. And so I come out and I say, oh, I am so sorry. What happened? And she said, you're the one who put a curse on my children. And I said, oh, I'm so sorry. I didn't mean to harm your children. Well, why do you think I cursed your babies? And she said, well, they're crying and they're screaming and they won't eat. And you never said that my babies are beautiful. You never said how fortunate I am to have such lovely children. And so you must envy my children and you must want them dead. And I thought to myself, gosh, a med student, they never taught me to compliment young mothers about their babies. And so I asked her, what do I need to do? How do I fix this situation? And she looked at me like, you don't know what to do? You must remove the curse. And I thought, remove the curse? I think I missed that lecture at UMKC. And so I put my hands on the babies and I raised my other hand to heaven and I prayed a blessing upon the children and a curse removed. And I could see the stress just melt away from her face, like she'd been through this before. And she says, okay, well, now I know my babies will be well. So observe the problem, try to understand why, make an adjustment. So here's another one that's a little bit less dramatic. This is baby Manuel, and his mother brought him to our little hospital in Angola in Southern Africa. And she said, my baby's sick, he had a bad skin infection and obviously malnourished. And so I asked her, what are you feeding him? Try to observe, try to get some information about the situation. And she says, well, I give him cornmeal, just like all the other kids, just like my mama gave me. Well, cornmeal in this culture has got no protein whatsoever. It's just pure carbohydrates. And so a lot of the children have got protein malnutrition. And so I said, could you help me understand why you only give them cornmeal. Just try to probe a little bit more. Well, it's the only thing available in the market. My mother-in-law says it's the only thing that, is that babies need. They just need cornmeal. And so meat is actually just for the men. The men in the family need meat so they can defend the family, and children don't need anything like that. And so this is how they make their cornmeal. It's just they grind up the corn seed after they shuck the ear, and they pound it until it's powder, and then they just boil it with some water, and that's it. And so I said, well, how about give them an egg? Oh, an egg? Yeah, I mean, we do have chickens, we do have eggs. And that didn't seem so radical to her. I could add some eggs to his cornmeal, and that way the man still gets the meat, but it was just an introduction of an idea that might help. So let me ask you one last question. All of these are expected outcomes of providing skilled cross-cultural care, except which one? Which one doesn't fit?
Maybe B, it doesn't really sound like you are including the patient.
Okay. Any other
I'm
thoughts?
reading it wrong.
Yeah, all of these are expected benefits of skilled cross-cultural care, except which one?
I mean, you ask tricky questions, I just want to say. So,
Thank
I
you.
mean, like I think about D, and I see Marie added that too, because it probably might take more time, especially initially as you're building relationship with someone, to actually understand that. So maybe, and I see D turned green, so.
Yeah. Right. So if you're dealing with someone who is culturally different from yourself, even if you both speak the same language, probably going to take more time, just to assure that the communication is successful, as we're moving forward. Well, in this talk today, so far, we have focused somewhat in our scenarios on other nations, but actually we've got people right here in Kansas City, who are minorities, who are undereducated, who have barriers to medical care. And one of the things that I love about working with you all at KUMC is this enthusiasm of, we want to do something on behalf of these people who are living on the margins. But there's questions connected with that kind of service. Do I need some special education? How do I select with whom to serve? It's a big world. Where do I focus my efforts? And it's for all these reasons that 20 years ago, I helped found the Institute for International Medicine. Our biggest event of the year is coming up 6 weeks from now, the last 2 days of May, the Humanitarian Health Conference. This is going to be the 19th year of this event here in Kansas City. And this is an opportunity to meet some of the leaders in this field, people who are serving both in Kansas City and in the US, as well as around the globe. And there will be about 20 organizations present who are interested in recruiting volunteers, people who are looking for service opportunities. There's also going to be opportunities for you to present your posters, and there are poster categories that have to do with clinical experience and actual scholarly research and service experience. So if you're interested in a poster presentation, that's an opportunity. And for students, we have got great funding. Normal registration is $200, but students it's just $20. And so this is the coupon code, Connect 2024, and the event website. And love to meet some of you in person. And then during the year, I work with KUMC and to arrange international rotations. So I have got faculty in 25 countries who are really interested in having students and residents, not only in medicine, but also in nursing and therapy and the other health professions, to do service experiences. And if you're interested in that, then I would encourage you to talk with Kimberly Connolly, who's on the call with us. And she will direct you how to get in touch with me, and we'll work out what the alternatives might be if you're interested in doing an international rotation. So it's really been fun talking together with all of you today. This is my email and my cell, and I would be happy to continue the conversation. So Alexa, I'll turn it back to you.
So this is a great opportunity. We have a few minutes to ask questions. I want to thank Dr. Kamenelis. As always, you engage everyone in the conversation, and your humility comes through in your willingness to engage everyone and hear other people's opinions and thoughts. And I think that shows what a great teacher you are. At the end of the day, you are definitely an educator, and it shows in your presentations. At this point, we were open to additional comments, questions. I did want to start with a thought, Dr. Kamenelis. As you very eloquently showed, there's a lot going on culturally with patients. And of course, we're all individuals with our own culture. I think there is some belief that you can learn all these different cultures, but of course we know that's impossible. So what's the general advice you would give our healthcare providers, our faculty, our residents and students about navigating different cultures?
I would start with get to know somebody from that culture. Do you really have a friend who is Hispanic? Do you really have a friend who is, raised in the Kansas City urban core? Do you really have a friend who is, from another country, an exchange student? The humanity, the respect that comes from some kind of personal experience with a person like that, I think is really powerful. I had a roommate in med school who was from Shanghai, China. And that was the first time I had ever known a Chinese person. There was nobody in Park Hill High School who from that. And so just that kind of personal interaction, I would recommend as a first step.
And I would add to that, if you don't mind, that by virtue of getting to know people from different cultures, it actually helps you deal with other cultures. So for example, you became friends with someone from Shanghai, a Chinese individual. That even helps you deal with people from other cultures that aren't the Chinese culture, because it starts to open your understanding about rules and expectations that they're different. Until we see differences, we think everybody is operating from the same rules, the same expectations. Like, this is how you're going to act, talk. This is what you're going to do. This is what you think about weight. It's all the same. Yeah. As an American, we think everybody wants to be skinny, those type of things. So as you get to talk to other people from different cultures, you realize there is such a great variance. Is that why you went to Shanghai, Dr. Kamenelis? Was having that friend, was that why you went to China? Was that a very influential relationship?
It was. And the other main reason is because my school had a relationship with that particular school in China. And as a compliment to you and your office, you all have got multiple relationships. And so, hey, everybody listening, this is one of the great reasons you're at KUMC, is because these pre-existing relationships are an avenue for you to experience other cultures and other kind of medical systems and get to know people from those places who are doing their work at the Med Center.
Mhm. Thank you. I appreciate you reminding people of what we have and to come to our office. What about our students who are on and learners? Anybody else have a comment or a question? Louisa, you've been very engaged. Cooper, thank you.
I do. I actually was going to ask Eve, you, with the experience you've had before, frequently find different health professionals that are not med students, because I'm a respiratory care student and I feel like I always see a lot of doctors, a lot of nurses, and sometimes even occupational therapy involved in these kind of experiences, but I never or hardly ever hear RTs being involved in how we can add value to those experiences.
Well, we have, as you know, a respiratory care trip that's interprofessional that goes to Ghana.
Yes.
Yes. So we do have lots of other healthcare, other areas of healthcare that are involved in international education and international collaborations. In fact, our respiratory care department is very engaged in global health, and they have actually done some things that are very unique and very, I would say, from a global health perspective, it's one of our great examples of paradigm shift where they have co-created with our partners. So in Ghana, for example, they collaborated with our partners to create respiratory care as a profession in Ghana. So that took a lot of effort of collaborating with the Ministry of Health, Ministry of Education to make that a profession. And then it was created as a program and a degree at the University of Ghana. And so now they have that actual healthcare profession in Ghana that's obviously supporting healthcare at at the hospitals. And those individuals of the first graduating class actually came to KUMC, so it's bi-directional. And Dr. Lisa Trujillo, Dr. Shell, they go back to Ghana, and they are, I would say, like advisors, still to the program and engaged with it. So they're some of our biggest leaders in global health at KUMC, and they sit on, well, Dr. Lisa Trujillo sits on our Global Health and International Education Faculty Forum, and she's part of the work group, which actually sets a lot of the, I would say, the kind of the culture of how we engage in global health. So we have a small work group, and she's on that.
Well, I actually wanted to add that I'm going to the Ghana trip, and I'm very close with Lisa and like the way she is managing these kind of trips, because I know she's also very involved with the faculty in Ghana. But I guess my question was more directed towards those of you who have experience, if you see the value of other healthcare providers or students or future providers being involved in those activities, because if it wasn't for Lisa and the way she has structured this whole trip, I don't think I've ever seen RTs or other professions besides med students and nursing be very involved in these kind of activities. So that's kind of where my question is going, because I would love to continue doing this down the road.
Yeah. And I'll let Dr. Kamenelis answer that a little bit, but I do want to say, I think that is what's unique about KUMC, Louisa, because OIP, we structure these international educational experiences for all of our students because we know that it's interprofessional and that interprofessional teams are needed. So we may have made opportunities and lots of bi-directional exchange for like School of Nursing and some of the other PT, OT, excuse me, and all of our students and all of our faculty and learners, and we don't just focus on medical students. And I do think that might be a little more unique about KUMC. But Dr. Kamen-Ellis, you've worked internationally with different teams. You want to speak to how other team members are needed and contribute?
So two things. One is that collaboration is of course really important, and it's also really interesting, you know, bringing people from different expertise and different experience. And the other thing is your dean, Dr. Akinwadu,
Dina Kinwantan,
is very engaged in this field, and having him as a leader is really a big plus for you, Lisa. And if you don't know him, please drop by his office and tell him, you know, about your interest and your experience, and he may be aware of other opportunities that would be really enlightening.
Yeah, I mean, it's interesting because Dina Kinwantan is the leader, as you all know, of the Global Health and International Education Exchange Faculty Forum. He's a PT, he's over the School of Health Professions. So it's not even a School of Medicine run, you know, initiative, so to speak. He is definitely seen as like the figurehead of global health at KUMC, which is different. And that kind of speaks, I think, Louisa, a little bit to what you're saying. And I do think KUMC is a little bit different than a lot of institutions. And it is something that we work towards because of medical missions, it's historically been medical, I would say, emphasized, medical student emphasized, that that's one of the areas also we look for transformative language, how we approach things, that it's all inclusive of all the health professions and not just medical and medical students. Yeah.
Thank you guys. I appreciate that.
And just one more thing about respiratory care that's interesting. So medical students exist all over the world in the profession of medicine. There may be shortages, but there are schools and it exists. Respiratory care is kind of interesting and exciting, Louisa, because as you know, not every country has that as a profession. And so our faculty, they developed it in Ghana, but we're currently working in other countries like Honduras. We have an active process of creating a respiratory care as a profession in Honduras. And we're going to have a group of Honduran doctors who would be the trainers and educators in Honduras. They're going to be here at the end of April, the last week of April. And this might be a good segue for our next presentation. And Alexa, you can jump in. They will be presenting, Alexa can tell us the date. They'll be presenting the week that they're here, that last week of April. And I'd love for you all to be at that presentation. They are not respiratory care therapists, but they are the faculty that will help teach the respiratory care program once it's established. Okay, anything else from anybody? All right, well, thank you so much, Dr. Kamen-Ellis. Again, we appreciate your willingness to always talk to our learners and our community. And Alexa will be giving a follow-up to everybody with the recording and with more information.
Thank you, everybody.
Thank you. Bye. And Cooper, if you wanted to hold on, you had a question, you can stay on if you want.
Yeah, it was pretty off topic.
Yeah. Alexa, will you